Thank you very much, Ian and Paul. And the workshop is now a workshop where you have to do the work as well as ourselves. So, are there any questions? And please say your name and where you come from, please.
I am Claire Thomas from Coventry. I was just wondering what value the panel thinks that other biomarkers such as calprotectin has in the detection of cancer.
Right, well, since I'm the chairman, I can give my point of view first. So there are, as you say, a number of potential biomarkers of value which are in the literature, M2PK, for example, and, as you say, calprotectin. We have done a study, as you may know, which is published in Gut. It's open access. The first author is Mowat C. And we looked at calprotectin and fecal hemoglobin and found that fecal hemoglobin is possibly a better test for the overall for ruling out significant colorectal disease, so including cancer and high-risk adenomas and IBD, than calprotectin. Calprotectin is very good at excluding IBD, but it's not very good in our hands for excluding cancer or other neoplastic lesions. But I saw that you had a poster here, so maybe you could tell us a wee bit about what you found.
Yeah, I'd have to agree with what you said. We measured hemoglobin and calprotectin in patients who are on the 2-week weight pathway, so symptomatic patients, and we found that actually measuring calprotectin didn't really add any value to the hemoglobin. It increases specificity a little bit, but it was at the expense of the sensitivity and the negative predictive value. So we found that just using fecal hemoglobin alone had an NPV of 99.4%. So it was very good as a rule-out test and didn't really need the addition of calprotectin.
And that's very interesting, because our 2 studies show exactly the same results, and yet the calprotectin and the fecal hemoglobin were done with different analytical systems. So personally, I think the role for calprotectin is in monitoring patients with known IBD, but obviously I'm sure Ian and Paul have views.
Can I just say, I think there's a possibility here that we've got 2 separate pathways. We've got the initial cancer referral pathway, and we're looking at fit in that. Once you've ruled out cancer as the cause of the symptoms, there may be a secondary pathway that you put people on, which might be a kind of a gastroenterology led pathway, which might include a calprotectin when you're doing subsequent investigations. But if you've got somebody with symptoms, the first thing you want to rule out is cancer and significant pathologies.
Yeah, I don't have anything to add. I agree exactly what you said there.
Thank you.
Thank you. Thank you, Claire. Other questions?
Martin Myers, Preston. This is a nice question as opposed to a fit question. I'm just a bit confused. You put it on your slide, Callum. It's 1.3.4. Offer testing for occult blood in faeces to assess colorectal cancer in adults without rectal bleeding who, and the second bullet point is, are aged under 60 with changes in their bowel habit or iron deficiency anemia. So that's causing a bit of confusion in my neck of the woods. So are we saying someone who's an adult, define that, anyone with an adult with iron deficiency anemia should be offered FIT?
Yes. Which
1.3.4.
Yeah. This is the new guideline,
Yes.
which specifies the use of tests for occult blood in faeces without being specific about which test. Yeah. Well, which? I can't remember all.
Yes. So it's confusing me, and if I got it wrong, I'll be quite pleased. But it says offer the test, and it's the second bullet point. Are aged under 60 with changes in their bowel habit or iron deficiency.
Iron deficiency. That's correct. And this is one of the areas in which the guideline has been criticised by some, because the BSG would say that anyone who has iron deficiency anemia should be referred probably for colonoscopy. So there's a conflict between the NICE guidelines and guidelines from other professional bodies. And there are also conflicts between what Claire and we have been doing with the NICE guideline on calprotectin.
So 23-year-old girl, lady, goes to a doc, feeling tired, does a full blood count, do a bit of biochemistry, iron deficiency. The next test is occult blood?
That's what the guideline would recommend.
Can I just step in there that perhaps just a little bit of clinical overlay here? If you've got a 23-year-old girl who's not got heavy periods and has got some GI symptoms, that may be the case. Where the issue also lies is often the gastroenterologist, they'll do upper and lower GI endoscopies. So the value in a fit test is which endoscopy do you do? So there's an age relation here. I mean, this is the exception. You don't rarely see 23-year-old girls who have got occult blood loss there, but it was also direct which way the test would go. But this is in keeping again with some abdominal symptoms as well.
Okay.
You can't just go on with the iron
But you
deficiency.
will get a lot of 23-year-old ladies with iron deficiency anemia.
Yeah.
I'm not suggesting they have an endoscopy, but I'm questioning whether they should have a fit.
Yeah. Yeah. The NICE guideline is full of ages, and they're all round numbers, 40, 50, 60. And if you actually look at the guideline, these were not decided upon evidence. Now, a lot of the recommendations in this particular guideline, when you read it, it's down to evidence plus personal experience, and that's the personal experience of the panel who did it.
It's Ian Walker from Berkshire. I think there's just a word missing there from the guidance. I think you proceed to further investigations in anybody with unexplained iron deficiency anemia. So, young woman with heavy periods, menorrhagia and so on.
Yeah.
No, I don't think we need to go further.
Yeah, I
But
cut it in paste.
IDA not otherwise explained is when you proceed on.
Yeah, that makes a bit more sense.
I had a question actually for the clinical perspective to this. The whole rationale of the 2-week rule, of course, is based around patient anxiety, because having been told by your doctor that, oh, you might have cancer, but probably not, obviously anxiety levels are immediately notched up to very high values, and it's unfair to leave people in that state of anxiety for more than a few weeks. Is there a risk here with an intermediate step that we're now telling people, well, we think you might have cancer, oh, and your fit test positive as well, which increases the risk even further? You're now ratcheting up the anxiety even more, oh, but we still can't do anything about it for 2 weeks.
That is, I mean, perhaps a victim of our own success here in that case. If the data supports the fact that you're more likely to have cancer, then that's it, it's in the public domain. They can look themselves. You're not going to allay anxiety here. That's not what the 2-week rule is about, I'm afraid. But yes, your patients will know, they will read, they come to me with documentation all the time and tell me that the chances of having cancer given their age, not with fit testing yet, but given their age and their hereditary status, the father had it, at the rest age of 50. So anxiety is thereabouts. I mean, by virtue of the fact that blokes go to doctors as well. I mean, it takes an awful lot to drive a man to a doctor with altered bowel habit, so they have to be highly worried to get there in the first place. So the 2-week rule there is not going to do anything with the fit test to allay any fears. I think it's just going to add the accuracy to what's happening there.
Is the converse not true though, that if you have a negative fit, that you could actually you've actually reduced the risk of cancer, and you might be able to allay some of these fears?
Yeah, certainly.
Could I ask a quick question?
Yeah.
While we're just waiting. One of the group that we're undecided on what to do with now is the group whereby you have symptomatic patients. They've been referred for a colonoscopy. They are fit negative. They still have symptoms. What are we going to do with that group?
Yeah, I think that is one of the real difficult questions to answer, because there are obviously a number of possibilities. You could watch and wait, see what happens. You could do another fit, but there's no literature to our knowledge on doing repeated fits in individuals, whether they're negative or positive. You could refer them to gastroenterology clinics, for example, or you could review the patient and then send them for colonoscopy. So there's a variety of options, and I think this is perhaps the area where a bit more research is needed. And as Ian told you, he is rolling out the use of FIT as a routine in NHS Lanarkshire, and we have begun doing this with a slightly different clinical pathway to Ian, and started in December, and we've already done about 1,500 FITs, and I believe that NHS Grampian are also going to start fairly soon. So the idea of using FIT is certainly rolling out over Scotland, and we will generate between us in the next couple of years a lot of information on what happens to both FIT positive and FIT negative individuals. So I think it really is a sort of watchless space in many ways, and the more people who get into using FIT, whether they do it as we are doing it, a sort of pilot rather than a full-blown routine test, we should generate the information that answers some of the really burning questions, because there are a lot of questions. It's not straightforward. Using FIT, the negative predictive value is high, it's 90-odd%. It's not 100%. So cases of significant colorectal disease are missed using this test, one test alone, for a whole variety of reasons. So there has to be some, as Ian is seeking, some really good safety netting, as they call it these days, to catch the people who really do have serious colorectal disease but are FIT negative. Yeah, Paul?
Yeah, that's absolutely right. I think looking at the guidelines are about, I think if you're FIT positive, you'll hit the pathway for cancer. If you're FIT negative, you're not going to be dismissed. So you're still going to be followed up. But as I alluded to in my talk, we are governed by time frames. It just means you can step outside that time frame, and FIT will allow us to do that. So you're not going to be ignored, you're not going to be investigated, but those people who have irritable bowel disease, where the symptoms mimic cancer, can be investigated that little bit more leisurely.
Caroline Chapman, Bowel Cancer Screening Programme, Eton Hub. I'm just asking, really, I can see within the 2-week wait, it's quite clear what we might be doing, but within the GP practices, what sort of cut-off are you using, and how is that not going to impact that bit more on the colonoscopy services at the moment?
The cut-off point that we are recommending, based on the evidence that's been gathered, would be, however you do it, to use the lower limit of quantitation of the analytical system. So for HM-JAK, we would use 9 micrograms or per gram. Below that is negative. Between that and 400 is a number which we would give to the GP, and above the 400 is above 400, greater than, you know. So the cut-off point is really low, and if you use undetectable or not detected using that sort of cut-off point, you would probably save 40 to 50% of referrals to colonoscopy. And remember that the amount of colorectal cancer in that sort of population is about, in our hands, is about 4%. So it really does make a significant difference. And although, as I said, it's very important to remember that no test is perfect, and you will miss cases, and you have to have safety netting. The evidence, and there's quite a lot of evidence now, if you add up together the numbers, is certainly that using a low cut-off, much, much lower than you would using FIT in a screening context. And that's really, really one of my things, a really important point, that we talk about FIT in screening, and you know that this is probably going to happen in England sometime. It's definitely going to happen in Scotland by early 2017. And we are advocating FIT in the symptomatic, but they really are very, very, very different. It's one test used in 2 very different clinical settings. The cut-off points are different, the way it's used is different, the outcomes from positive and negative are different. And it's very, very important not to translate the huge literature on the use of FIT in screening asymptomatic populations into using FIT in assessment of the symptomatic. They are apples and oranges, and they are very, very different. Look at the literature for the orange, look at the literature for the apple, but certainly don't confuse the two.
And I think that's important, that that's actually what NICE are looking at in the diagnostic assessment programme. It's solely the symptomatic patient.
So I just wanted to ask some questions about the nitty-gritty of the actual sampling system. So in these studies, is it the case that the patients provided a sample of faeces which were then sampled by the laboratory professionals?
No,
Is there a risk
Yeah.
that if the patient does the actual sample collection for the test, that there could be a risk that you'd miss the presence of occult blood because the actual sample doesn't contain a representative, homogeneous, sample of that sample, if that makes sense?
Yeah, that's a really interesting question, and what everyone again should remember is that fecal hemoglobin is actually in faeces is very, very, very unstable, and therefore the fecal sample must be collected into the specimen collection devices, whether they're cards or tubes, immediately after the stool is passed. So the patient puts toilet paper or some other sort of collection device, the stool is passed and it is collected into the specimen collection device, which contains preservatives in the buffer to ensure that the sample is stable. So the collection, using those blue capped pots that we traditionally use for fecal samples, is seriously out. You will get false negative results and it just will not be right. And like getting a glucose sample in an unpreserved container, you don't do those. Getting a sample is hemolyzed, you don't measure potassium usually, it's hemolyzed. Getting a blue pot, you don't do fit, in my opinion, and there's good evidence to back that up. Yeah?
I was just going to say, I mean, in terms of the possible negative results because you haven't got a kind of a homogeneous sample, it is the inherent risk of using faeces as a sample media. It does. Most of the time, the hemoglobin will be mixed throughout the fecal sample, but you will occasionally you will miss it. It's an inherent risk. Same with salivary samples and things like that for other tests.
So is it the case that once this is rolled out, you're not going to get the same negative predictive value that you've achieved in the studies?
Probably not. In our, as I say, we've done 1,500 sort of routine ones, and there is one patient who has cancer that has a negative. And this is because the patient had obstruction of the bowel, and fecal hemoglobin, as I say, is really quite unstable, especially as it transits through the colon. So if your gut transit is very slow, then you won't have detectable hemoglobin in your faeces. And if you actually, sort of more academic perhaps, women have a lower, much lower fecal hemoglobin concentration than men do, because women have longer gut transit than men do. So it all, the basic science and what we find in practice does actually fit very, very nicely together.
Very, very similar question actually, it slightly overlaps, is how biologically variable within individuals is hemoglobin. It sounds like it is, and therefore is there any potential value of a second test in symptomatic patients for a negative first test? Has anybody looked at that?
Yeah, the answer to that is we would like to find out, because we don't know, and there is no literature on the biological variation of fecal hemoglobin in either those persons who have cancer, which would be interesting in itself, and those people who have a negative result. Do they go from negative, positive, negative, positive? Yeah. It's something that really needs to be looked at very seriously, and good evidence found.
Yeah, we've tested an individual who tested negative in secondary care, and then retested them again when we found they had cancer, and they came up positive second time around.
I think one of the things is, especially when you're looking at things like high-risk polyps, is the polyp needs to actively be bleeding at that particular time in order to give a positive result. If you haven't got any bleed, you won't get a positive result. I mean, I looked at, of our sampling, we ended up with about, I think it was 59 patients who had a negative result, but actually on colonoscopy had some significant pathology there. It might not have ever been the cause of their symptoms, we don't know. It might not be, obviously wasn't bleeding at that point, but there were polyps and things in those people's guts.
Other points?
Thank you.
Alison Jones from York. We're doing a little bit of research in our laboratory, supported by Alpha, actually looking at fit in a research setting, and word has got out that we have the ability to measure fit. There's a lot of tension between primary care, who've picked up on the NICE guidelines, and secondary care, who currently don't have the appropriate pathways in place for the introduction of occult blood testing to work through a referral pathway. And being the NHS England, a lot of this centres around money. Who's going to pay for it?
Yeah.
Can I just ask the two members of our panel who do have a routine fit service now, where the funding came from for the introduction of that service, and whether it was done off the back of a business case in terms of patient pathways and cost saving further down the line?
Yeah, I mean, I'll quite happily answer that if you want to start with. We have the joys of working in Scotland, where we don't have separate primary care, secondary care. We're all one big health board. So it's not so much a case of I'm charging primary care for the specimens. It is a difficult one. Where does this test fit? Fit again. But what we do is we've actually agreed a transfer of the budget from our surgical budget through into the laboratory budget to cover this. But it is an area where you will have to have negotiation. When we set this up, we ended up having to get together the correct parties in order to make it work. We had representatives from primary care, we had representatives from public health because we've got to get that message out there in terms of sampling. We had gastroenterology, surgery and the laboratories. It has to be an agreement between all those parties.
Yeah, we've done things slightly differently. In England you have the Be Clear on Cancer campaign. So in Scotland they have this Detect Cancer Early campaign, and they've got loads of money. So they spend loads of money on causing great numbers of people to be referred for colonoscopy. But in NHS Tayside, the Detect Cancer Early initiative is funding the pilot, and we also got £300,000 from the Scottish office to progress it. But our Cabinet Secretary for Health, Wellbeing and Sport, the equivalent of your Jeremy Hunt, said publicly, if this in Tayside is successful, it will be rolled out all over Scotland. So just like the screening programme is well on the way of getting fit as a first-line test, I think partly because of, and maybe mainly because of the funding, and partly because, you know, we have had a long-standing interest in fecal tests and been involved with screening programmes in Scotland. We're kind of a wee bit ahead of you guys, I think, in looking at the pitfalls as well as the benefits of using FIT in the assessment of the symptomatic in primary care.
And has anybody done a retrospective economic analysis of whether, I mean, you talked about the budget being transferred from surgery into the laboratory. Has anybody looked at that and whether there is actually the books balance when that's done?
Not that I'm aware of as yet.
Right, we have to draw this to a close, unfortunately, because I see there are some hands still about. It's been really interesting, it's been fascinating to listen to your questions. Thank you very much, all of you, for participating, and thank you to Ian and Paul for providing some of the background information.